All right, so hello world again. Today it's a very interesting day. I have here Dr. William Bridge. How are you, Dr. William?
I'm doing well, man. How's it going?
Pretty good, pretty good. Um, Thank you for coming on this platform, especially on short notice. I wasn't expecting that, but I very much honor this appearance. And I'm very glad, just so the platform can know, you are a practicing psychiatrist in North Carolina, and you created a page called Concierge Psychiatrist. Do you mind telling the audience about that?
Yeah, so the Concierge Psychiatrist Instagram page basically, is just my way of spreading awareness for mental health. I kind of put in the write-up of the profile that it's psychiatry both for providers as well as patients, So I have some educational content in there as well, but, definitely content that the patients can see and get feedback from patients and other mental health practitioners around the globe. So that's my intent behind it, and it's just getting started. So I'm interested to see where it takes me. And thanks so much for having me on today. I'm happy to speak with you and address some of the things you'd like to talk about here.
Oh, no, absolutely. And no, and thank you, to be honest. And one of the first things why I wanted to bring you on was because you are a practicing psychiatrist, Dr. Bridge. And today I had a friend tell me that they went to see a psychiatrist, they did a quick assessment, and at the end they prescribed the medication. So I was wondering, what is, from your experience in the field, how your coworkers or people that you have worked with, or just your knowledge from going to certain events, how is mental health being addressed in your field as a medical professional? Because right now um, there's a big issue where the pharmaceutical companies and the pharmaceutical industry have a strong hold on the mental health field. As you see with the DSM, they're part of the board. So I was just wondering what you're seeing in the field and what you're seeing from the people you're working with.
Yes, so in a scenario similar to your friend, sounds like presenting to an outpatient psychiatry office. Usually in those encounters, a couple of things come to mind. So where I practice at that established care time slot, I'm very fortunate in that those appointment intervals are 80 to 90 minutes. So it's definitely a substantial intake evaluation that gets done when you're first meeting, evaluating, and assessing a patient. So, that's number one. I think it's good if you are going to be pursuing an outpatient psychiatrist that, it's an important question to find out, is this initial evaluation for establishing care, is this a 15-minute ordeal, or, is this going to be a comprehensive review of the patient's entire lifelong history? So so in clinics such as the one that I work at sometimes, I would say that it's important to always discuss with the patients at the conclusion of the appointments what you think, if any, the diagnosis is. And I think it's important to emphasize that there are times where I see a patient for the first time in an established care and there is no diagnosis, which means there is no treatment. And basically they come, kind of get reassured that there's nothing that needs to be treated, or sometimes the reassurance comes from the diagnosis that you give. But I would say in short that I like to discuss the diagnosis if there is one with the patient, and then when it comes to treatment options, I think that always the best decisions that are made between patients and providers are done in unison. So I like to give my patients options, at least 2, maybe 4 options where they can pick, and we can kind of discuss the pros and cons of each of those options. And of course, one option is also to not take medicine and, consider referral to psychologists for psychotherapy, or therapists, whether it's substance abuse counseling or whatever it may be. So, I think, generally it's important to communicate well with the patient so they don't leave wondering what your thoughts were, where your diagnosis was headed.
Wow, that is actually great information, and I wanted to piggyback off some of that information. So when a client comes in, what is the instrument that you are using to try and obtain a diagnosis, if there is one? What instrument are you using, Dr. Bridge?
Sure. So so basically, my personal approach to the interview is I try to take the interview almost in a chronological order. So, in speaking with the patient, I start off with, trying to have a clear understanding at what brought them to the appointment. And then I kind of, work back from, maybe the initial time that they started having, concerns about their depression, anxiety, insomnia, or social phobia, whatever the case may be, and kind of just really try to keep the interview with the patient open-ended and almost conversational. I've found that some of these interview tools, as they're sold or marketed, it can come off as you're just kind of going through a checklist with your patient, as opposed to really, listening to what they're saying. And I don't take any notes during my interview with the patients. I don't type at all. That way, I find that I'm able to really listen as much as I can to what they're saying. And, if it does come up, to the point where I feel like their diagnosis is major depressive disorder or generalized anxiety disorder, there's at that point, there are scales that you can give to the patients, like the GAD-7 for generalized anxiety, or you can go through the PHQ-9 for major depressive disorder, or you could, there's a multitude of different other tools that come about. So when it comes to formulating a diagnosis, the major tool is the DSM, which, kind of comes into play when you're doing your summary assessment and diagnosis within your consultation note. But that kind of is my approach when it comes to tools and so forth.
And so from what I'm hearing is you kind of go in a chronological order. What brought them there? When was the beginning concerns? And once you start seeing what the client is saying or the patient is saying, then you start trying to find the right instrument that you're going to use to kind of measure what's going on. Did I get that right?
Yes, that's exactly right. And, one of the things that, I try to, kind of give the patient an important analogy behind is that when they're describing some of the symptoms, if it is depression, I try to make it very clear that, the symptoms of depression, such as guilt or low energy or irritability, those symptoms of depression are as real as, the fever, cough, and sputum production of pneumonia. So just like we have ways to treat fevers in pneumonia, we have ways to address poor motivation in major depressive disorder. So that way, I do my best to kind of reduce the stigma and, get the patient comfortable during the evaluation. So they open up as much as possible. But of course, that's a relationship that builds over time.
And I'm glad you brought that up. How important is it? Because where I'm a substance abuse counselor, prevention therapist, and it's so important in the beginning stages, even after I'm required to do certain assessments and certain evaluations, for me to build that rapport with the client. And sometimes that can take a while, especially when some of the clients, they're struggling with trauma and trust issues from parenting styles that they were engaged in, and so on and so forth. How important is that rapport building with the client as a practicing psychiatrist?
Yeah, so I think that, it definitely holds a lot of weight in terms of the productivity of, your sessions. And I think it's important to highlight up front that some of the best rapports that I've built with patients over the years have come from the fact that during that initial evaluation, that it was okay for them to not really open up. Once they see that if they make it clear to their provider that at this point in time they're not really comfortable speaking on a certain topic, whether it's psychological trauma or combat veterans or history of physical, social neglect, that type of thing. So I think it's very important to let them know that you're not going to be prodding until you get an answer, because they're that much more likely to open up. And especially, that goes along with your field and specialty as well when it comes to substance abuse. Sometimes that's something that won't come out until the second or third, appointment with me. But is that kind of been your take with the patients you see for substance abuse counseling and so forth?
Yes, I typically work with adolescents. I also work with adults, but mostly my experience has been with adolescents. And I find that it takes a while to build a rapport with the adolescents, especially oftentimes when I do the first initial intake or assessment, the parents are involved, and I do like them to be involved. Obviously, in the field, the client isn't going to tell me everything, and when they do tell me things, they're oftentimes neglecting certain facts that happened, or they cater the story a certain way. I need the parents involved. But you're right. Once in the beginning, if I make it okay for them not to say anything or not tell me everything fully in the beginning, then that's so crucial moving forward, because they'll feel comfortable, like if I'm not constantly pursuing that type of information. And I'm very glad that you shared that, because in my school, they taught us that rapport building and the relationship you have with the client is everything. And I was always wondering, in your field, which we share, the mental health field, but as a psychiatrist, you have to see a lot of patients. And I always got the impression that, and tell me if I'm wrong, Dr. Gray, if I'm learning, I'm a student, or I'm a journeyman just like yourself. And I always got the impression that psychiatrists were under a certain pressure to prescribe certain medication. And maybe you can destroy that stigma for me or amplify it for me, and also for the platform itself. Is that true, or is that false, what I've been thinking about all the time?
Yeah, so there's a lot out there about psychopharmacology and kind of where it's headed and what's going on with it. What I would say is that for some of the oldest medications that, in my opinion, work the best, your antidepressants such as Zoloft and Prozac, or your mood stabilizers such as lithium and Depakote, or antipsychotics such as, Haldol or Zyprexa. I think that, these are medicines that have been around a while, and they're very affordable. They make generic versions of them. And, from, a psychiatric provider standpoint, there's in no way any pressure to prescribe any of these medicines. Now, where I think the stigma comes from, would be, something along the lines of, these newer agents where, you have a pharmaceutical rep that's maybe has a dinner somewhere and does a presentation on a newer atypical such as, Latuda or lorazepam. So that's kind of where I think some of the stigma comes along. And, when these reps come to the office and they're pitching the latest, tardive dyskinesia medication or mood stabilizer, you know, they have a job, and, you know, they can be very informative and educational about the medicines. But, you know, psychiatrists in no way are compensated based on any of the prescribing. It seems like a lot of that really kind of died down in the early 80s. So for the most part, it's illegal for any of these kickbacks, as they used to call them, to go on these days. So, you know, and to be honest, my humble opinion is that the newer agents don't really work as well, and they're less studied. So I find myself prescribing less and less of them. Does that answer the question?
Yeah, and thank you, Dr. Bridge. Thank you so much, because you're not only breaking the stigma for myself, but for the whole platform. So what you just said was you're not under any pressure to prescribe certain medications, or if you don't meet a quota or a limit, you won't get compensated. Whatever the case is, you're not under any sort of pressure. Then that's what I'm hearing.
Yeah, I mean, you know, to be honest, where a lot of it is going in terms of, you know, where the pressure is coming from, you know, and this isn't just psychiatry. I work on in internal medicine as well. A lot of it is going towards patient satisfaction, you know. So, you know, if you're, you know, pushing one medication or the other, I think that it's actually in the long run going to hurt you more than help you, just because if the patient feels subjected to pressure in any such way, you know, your satisfaction scores are going to be pretty dismal, to say the least.
Yeah, and thank you so much for clarifying that. And you kind of broke a stigma for me right now, and I'm telling you right now, a stigma was just broken for me. And it's actually kind of relieving, because, as I mentioned earlier in the interview, the pharmaceutical industry does have a grasp on, for example, the DSM. I forgot the exact percentages, so it wouldn't be fair for me to throw out some numbers out there. But I remember enough to say there's a decently big percentage that the pharmaceutical companies or its representatives are within the DSM board. And that is very concerning for mental health professionals such as myself. And I'm so glad that we get to work alongside psychiatrists such as yourself, who's obviously very involved in the client's mental health and in their well-being overall, and not trying to just prescribe medication, which I guess living here in Miami, I've had a different impression. And I guess my stigma developed when I see my grandparents, or whatever the case, go to the doctor or the psychiatrist, they're in and out within 15 minutes with prescriptions. And I just always feel like that's not the right way to go about it. But medical professionals such as yourself seem very informed, and they seem to be doing the right thing. So I appreciate that, Dr. Bridge. Now, going on to my what we were talking about a little earlier, if you don't mind, you said that the diagnosis leads to the treatment orientation that you're going to engage, the theoretical orientation or the possible treatment, whether it be through medicine or through therapy. What happens if there isn't a diagnosis? Do you still engage the client in treatment? Do you refer them out? What happens there?
So in the cases of patients that, you know, at the conclusion of the interview, you know, I felt as though, you know, they didn't have a diagnosis. You know, in my experience, it's been that even if there, you know, wasn't, if they didn't leave with a diagnosis, they found it therapeutically beneficial to just be there and really, you know, kind of discuss some of their past. You know, I always say, you know, in a perfect world, everybody would speak with a psychiatrist in a, you know, clinical setting, and it doesn't come from the standpoint where there's something wrong with everybody, more so that, you know, it's unlikely that there's people that don't benefit from talking about their lives. It's either feels good to speak about the highlights of your past, or it feels good to have somebody to vent to about the stressors. So usually I offer them, you know, a few options. The first one is, you know, to, you know, consider coming back for a follow-up appointment, just so, you know, we can say, and, you know, typically after I do an established care evaluation, I try to see everybody back in 4 to 6 weeks, no matter the case. So if they're open to that, we can kind of, revisit the idea of how things are going, and, maybe them coming to the appointments is all they need. Or maybe it'll come out that in the follow-up appointment, they end up telling you something that wasn't revealed in the initial assessment, whether it's, alcohol use disorder or benzo use disorder. Of course, opioids epidemic is a big thing these days. So sometimes diagnosis can develop down the line, and that kind of goes back to what we were talking about when, it's okay to not reveal everything to your provider during that initial evaluation, because, there's more than one assessment that usually takes place. So, they can all, of course, they can follow up with me. If it comes out that it's maybe a specific problem that can better be addressed by somebody in a particular niche, such as, marriage family therapist or substance abuse or cultural dynamic therapy or PTSD, if there's some other provider that I think would be better suited. I have a lot of connections in the community, and I try to get them plugged in within a reasonable time, because I think sometimes the established care way to my clinic is 5 or 6 months out. And, by then, if there is a mental illness, it can really progress. So it's a way to kind of get plugged into resources. And if they're not going to continue to see me, I try to plug them in with somebody who will be very helpful.
Oh, okay. And that answered my question to the T. And thank you so much again for being on this platform. I was gonna ask now, when there is a necessity for psychotropic medication and such, and you feel the need to prescribe it, or your coworkers or a psychiatrist or whoever, how often, though, Dr. Bridge, do you get see someone where you prescribe something and all of a sudden you start seeing that they can't operate without it? Because benzo addiction and opioid addiction is a big thing now, like you said. So have you ever witnessed something of that sort? And if you have, what were the next steps involved?
Yeah, so I think it's very important when you're dealing with patients in a specialty such as psychiatry, is that it's been my take that it's very important to the initial steps of treatment of any given disorder should be attempted with things that are non-addictive. And it's pretty basic. You have these controlled substances and you have these non-controlled substances. So, I guess putting it into a sample, if somebody comes to me with a generalized anxiety disorder, I would be doing that patient a disservice if, on that initial appointment, I say, here is 0.5 of Ativan, take this 3 times a day as needed for anxiety, knowing that the gold standard of therapy is an SSRI that really should be maximized as much as you can, because those anxiolytic properties are better seen at the higher doses of medicines, and try multiple things before you get them to, the addictive potential of benzodiazepines such as lorazepam and diazepam and so forth. So, it's always been my take is those should be used as last resort medicines. Now, it's a different approach when you are seen or you refer a patient who is seen by some other provider that maybe started with that, and now it's your job to get them off of the addicted substances and onto something non-addictive. Kind of flips the process, but it's tough because those medications work well, their side effect profile is very low, and it's hard to imagine some of these patients doing equally as well with something less potent or less deliberate, so to speak.
And how is that process when someone is going in to see you because you're with the goal in mind of trying to get off this whatever medication they're on, that there was a reason why they got referred to you, that they're addicted. What's the process to get them off it? What are the challenges involved and so forth?
So, I think the biggest thing is, close follow-up. And the second part of that is, not setting unrealistic goals for the patient. You want to set the patients up for success and not failure. So in something like benzodiazepines, it's always been my feeling that these were medications that came out to be prescribed in short-term 2 to 4 week periods of time that gets a patient through a difficult rut in their life. But what I'm finding is that these medicines are being used for years at a time. So when they come to me and it's time to deliver the news that you think they would be doing better without the medicine, I usually try something, along the lines of really only trying to cut down on 1 to 2 doses per week of what the medicine is. So if they have the ability to, take 21 doses a week, 3 times a day, 7 days a week, and I see them back in, let's say 4 weeks, over that time, the first week I'd have them try to only take 20 doses. Second week, maybe 19 to 18. Third week, 16 to 14. And then when they're seeing me back, they should really only be around 12 or 13 doses a week. And it may seem like not that much of a success. However, what I would say is that, they're taking 50% less of a very addictive medicine. And these patients are, do fine on it when they're 40, but they end up on it for, 15 years. And at age 55, it becomes a fall risk. And I see them on the medicine side with hip fractures. And, so I think, delivering the news that your reasoning behind why you think they'd be better off of it, and not setting unrealistic goals and expectations is the key to reducing the addictive potential if it's there.
Thank you so much for answering that question. So it's a gradual process, and close follow-up is very important as far as unrealistic goals, which is so crucial not only for psychiatrists but also for mental health professionals in setting realistic goals in the treatment plan and etc. Well, the next question I had for you, if you don't mind, is you had mentioned earlier that you're a practicing psychiatrist, obviously, and you practice in North Carolina. For those that are studying psychiatry or those that are interested in the psychology field, what are the steps? Do you feel like you actually get to have patient care and focus on that being a psychiatrist? Because as a practicing clinician, much like sometimes I get intensive outpatient and outpatient, I do follow-up calls if I know that it's needed. I only have a caseload of about 10 to 15 clients at a time, but I have no idea how it is for a psychiatrist. Do you get to focus on that patient care the way that you want to focus on, Dr. Bridge?
So I think that, my advice is that during your training, whether it's medical school or your master's program or, your doctorate program in psychology, whatever, setting that you're in, I think there becomes a time in your training where you start to ask yourself, or you start to just realize naturally that, maybe your style or your approach is better suited for an inpatient setting, or maybe you like the schedule or the workflow of an outpatient setting. So, that's the biggest question, what clinical setting do you see yourself in? And once you kind of figure that out, I would say that then you kind of, look within that, inpatient setting, for example. So if you end up in inpatient, do you want to be on the consult side of things? Like when I'm covering the consult liaison service at the hospital, we have a psychologist that rounds with us to help kind of, the psychotherapy side of patients or grieving with loss or teasing out addiction potential, that type of thing. So, I personally, I do outpatient a half day per week, but I kind of find myself better suited for the inpatient setting. I find that patients that come in very acutely sick, whether it's psychosis or suicidal or withdrawing, whatever the acuity may be, I like intervening right away. I kind of think of it as, time is brain, just like the cardiologist, will speak about, these interventional cardiac caths, and after the patient has a myocardial infarction, how long until they can intervene and that amount of heart muscle is saved. I kind of feel the brain is the same way. And these, there's a nationwide problem with patients boarding in emergency rooms, just basically sitting there waiting to be placed in an inpatient psych facility. So I think that's part of, what needs to change in mental health. More providers like yourself are part of, what's needed. But I would, advocate that, at some point in your training, you need to talk with somebody that's really been on both sides, and ask the questions you need to figure out what you're most comfortable in. And, that way you're doing a job that you want to do, because, your patients will know if you're there and don't want to be. So that's my advice from that standpoint.
Yeah. Yep. That's so interesting. And I'm so glad you brought up that topic, Dr. Bridge, because what suits the clinician best as far as outpatient and residential. I worked in a residential substance abuse / mental health as a secondary component here in Miami, Florida, but as a BHT for 2 to 3 years. And that can be tough. Can you talk a little bit about how oftentimes you talked about the placement and how that needs to change? Or we're going to get into that, but how sometimes you being a clinical professional such as yourself, how sometimes the client goes in and they may probably not relate to you, may not like you, because that's tough. It's not like they teach you in the schools where the client wants to see you and they put this whole image of like how therapy is supposed to be. But what's actually happening sometimes can be a little rough, especially if you have a client who's not willing to cooperate with either the treatment plan or whether you collaborated with them on the treatment plan, which is the way it's supposed to be. And all of a sudden you don't find them engaged and maybe they don't like you. How do you handle that adversity as a clinician?
Yeah, I think that my approach has always been that, if you feel as though you're not connecting with the patient for one reason or another, the initial thing that I think I would say the best next step is to communicate that to the patient, that you feel as though there's something that is missing. And I think part of it is knowing that it's there. And if you ask them directly, I think number one, the patients will respect that that you were aware of it, number one, and number two, were willing to bring it to the surface. So I would address it, and the most important thing is to not act like it doesn't exist, because the therapeutic relationship will really just be treadmilling it, so to speak. You won't really gain any ground if you feel like the connection is not there. So, I think that's, I always try to amend any kind of, missing pieces if I can. But, at the end of the day, no matter what specialty that you're in healthcare, there's going to be, patients that, will just do better for, you know, one reason or the other. So, you know, I do have colleagues in the, you know, local community that can refer patients to that, you know, I think may or may not be a better fit for a patient. So try to, you know, stick with the patient, but, you know, address the differences, and, you know, if it doesn't work out, it doesn't work out. But, you know, it's part of my responsibility to set them up with somebody that can help, you know, as opposed to, you know, this clinic relationship is now terminated, and, you know, kind of, you know, just leave them without a resource. So always try to make referrals so that they can pick up the care where it left off.
And that can be somewhat tough sometimes, making that referral, because there's a lack of adequate mental health providers and there's a waiting list. And I'll give you an example, which I'm sure you're aware of, but just so the listeners get to see that here in Miami, Florida, we don't have an adolescent female residential facility, whether it be for substance abuse or mental health. And the last one that we had closed down, and now there's a big thing in the community down here, whether it be in Key West or Miami, Florida, or in Broward, because there's no facility if an adolescent female needs those services. Instead, they put them into intensive outpatient. The judges will refer them, or the parents will take them to Citrus. They'll stay there 3 days. They'll be evaluated, and then all of a sudden they'll get referred to a therapist. When intensive outpatient isn't going to work, you know, I can try, or the clinician can try, and there has been success, but for the most part, there isn't, because they need a higher level of care. There's a lot going on. That 2 to 3 visits a week isn't going to cut it. So, how can, I don't want to say how can we improve, but what is it that we can, as a community, because we're both in the healthcare system, what is it that we can probably do to help that come about? I've tried doing a website, Instagram, but that isn't going to do any real legislative changes. That's not going to really do anything. And what do you recommend that we do as professionals?
So I think that, you know, the best way is to take a look at those facilities that, you know, already have mental health or behavioral health beds within them. And, you know, starting, you know, at them, whether it's a standalone community hospital or a larger university center. And I think it's, you know, just advocating through the hospital administration, you know, for example, there's, you know, hospital that I'm currently working at that used to have child and adolescent inpatient unit. And back in the, you know, late 70s, early 80s, they couldn't keep the beds full, and it ended up getting changed around and turned into an intellectually disabled 8 or 10 bed unit. But now we see that now we have these child and adolescents, for one reason or another, 5 or 6 of them boarding in the emergency room in North Carolina here at any given time. So we kind of went to the hospital administration, and now they're advocating to, you know, open up a 20+ bed unit. So I think, you know, starting small, the best way to gain ground is that with the regulation, and you know, it's kind of like a lot of things in healthcare are kind of you know, like paralysis via analysis, you know, so that there's so many different people that need to be involved that nothing happens, you know. So my opinion is that you should take a look at the facilities that already have the approval, and then start there, and, you know, seeing how much of a realistic short-term goal is it to have 4 beds or, you know, 6 beds, and it can always, you know, go up and go down, but that's kind of what I've seen in the southeast side of things.
Oh my gosh, Dr. Bridge, I'm so glad to have you on this platform, and I know we've been interviewing for a while.
Sure.
It's been a little bit, I wasn't prepared for this interview. I have one more thing I want to touch on before I let you go, if you don't mind. I know you're very busy and you're on call, which is here with the DSM. It's like a list of criteria that a person does a checklist almost, and then they get diagnosed. That's meeting the strict criteria of the DSM. The DSM now is being subdued, and the World Health Organization is starting to take a step up. I think the World Health Organization isn't going to use the DSM anymore as a classification for diagnosis. They're taking it from a 2-dimensional model to an 8-dimensional model, I believe, or maybe even 10. I have to double check that. I just want to hear your opinion as a practicing medical professional, and a great one from the responses you've given me, honestly, Dr. Bridge. What are your opinions on that? And where do you see the field heading now that the World Health Organization isn't really looking at the DSM as a reliable and valid source for mental health?
Yeah, and I think that, I appreciate your compliments. And I think that one of the things, that comes up with the DSM, so the first edition of the DSM was printed in the early 1950s, and it was around 130 pages, almost like a very thin pamphlet or brochure, so to speak. And now
catered with Freud. I'm so sorry to interrupt. Yeah, just catered for Freud's theory, and he was like the catalyst for that. Better start right.
Yeah, exactly. And now you flash forward to the DSM-5, which really just came out in the past couple of years, and it's 300 plus pages, depending on which format you use. But the printed version, that's the full copy, is 900 pages, and it has over 300 diagnosis versions within it. So I think that a lot of the, problem or challenges the DSM faces from the outside community is that, its growth, over the past, 70 years, its size is, almost 9 times larger, so now when it comes to the World Health Organization, so in medicine we have every specialty kind of has their administrative boards, and the big one in psychiatry is the APA. So I think when it comes to World Health Organizations, I think that, they kind of have the 30,000 foot view, flyover view of a particular specialty. And, it's important to kind of, if medicine didn't need to be specialized, it wouldn't be. So, I think if you look at any of the top boards, like the, Board of Internal Medicine, and the Board of Psychiatry or Addiction Medicine, that's really where I think the best resource of information and current, guidelines are found. When you look at the World Health, you're getting kind of like these, a little bit of like a flyover. You look at a specialty, you say, this book is questionable and you can't use it for one sense or another. But, anybody I feel that is within the realm of psychiatry nowadays, that is the really the spinal column of the specialty, the DSM. So it's hard to imagine substantial grounds in terms of treatment, diagnosis, and assessment without it. So just be careful with who you're listening to, especially the internet and the access to information these days. Got to screen the information coming in an appropriate fashion.
Thank you so much, Dr. Bridges. And I think with that, we'll leave the interview. And I just want to thank you for coming on this platform. I'm sure the followers and the subscribers and all that also appreciate it as well. And it's really an honor to talk to someone of your status, and not just because of your status, but also from the way that you answer the questions. I can tell that you really actually care about the clients, and you're not just going in there prescribing whatever, and which was actually one of the main, how we started the interview. And I really admire you and I appreciate you so much. I'm definitely going to keep in touch, not only for myself, but for the followers in general. I'd love to have you on this platform again, and we can have a very interesting and in-depth conversation and not just a flyover. Okay?
Yeah, absolutely. Just, contact me anytime, and, thanks for having me. I'd like to, maybe do some interviews or some discussions about addiction psychiatry and some of what we're seeing, both from your side as well as my side. So there's lots of interesting topics that we can talk about, and, definitely look forward to working with you in the future.
Thank you, Dr. Bridges, all right?
All right. Take care. Thanks again for your time.